I'm Dr. Zaid Fadul, and today this is the inaugural podcast for the Bespoke Physician Podcast. Our goal is to provide our patients of our practice and the general viewing public really good insight into what we value to improve the quality of care and the quality of life of all of our patients. I'm joined today by Dr. Phyllis Nsiah-Kumi, affectionately known as Doc Kumi. She is our Chief Women's Health Officer. We'll get into that in a bit. And she's here today and indulging us because we want to focus on why there is such a tremendous gap in healthcare. The biggest gap I'm seeing is the fact that half the population for half their lives get ignored with some of the biggest symptoms. And we're talking specifically about women's health.
Well, thanks, Dr. Fadul. I'm excited to talk to you about women's health in general, but midlife women's health specifically, because that is a huge blind spot for the healthcare system and for the population in general. So I'm looking forward to chatting with you and hoping that we can educate folks on what they need to be aware of, because it's a really big deal.
No, it is. And it's a big deal in my house. My wife is 36, and as she progresses, through life, I am very focused on the issues that affect her. And I realize how, frankly, ignorant of it I've been. As we've had children, I care about those issues and pregnancy and those issues and breastfeeding those issues. And this is the next stage. I see it coming, and I want to be better prepared because I've been woefully unprepared by med school and, frankly, residency. And I think it's a great opportunity for all of us to learn together. So
I agree. I mean, I think healthcare professionals in general are realizing that this is a blind spot. Nobody trained us. The patients need it. And we have to go out and figure out how to get it done so we can do the best for everyone we take care of.
Totally agree. All right, Dr. Kumi, now we've kind of set the table there, I want to focus on you a little bit. You are a fascinating physician. We're lucky to have you join the practice. So I'll just run through your credentials very quickly so everybody kind of understands who we're talking to. You've got your medical doctorate from Case Western. You trained in internal medicine and Med-Peds, which is pretty cool. You also have a master's in public health with a focus on health literacy. And I want to dive into that a little bit. So, internal medicine and pediatrics, like one focus on adult, one focus on kids. You chose to do both. Give me a little, help me understand that. What was the mindset? Why not choose family medicine like the rest of us cool kids out there?
You guys are out there delivering babies. So there's that. So you guys are doing medicine, peds, and OB. So let's be clear.
Yeah.
But for me, honestly, when I entered med school and entered my training, my goal was to do pediatrics. And so to do pediatric subspecialty. And one of the things that I noticed in that subspecialty was that as those young people were transitioning from pediatrics to adult care, there was kind of a black hole. And so they would, in peds, there's a lot of hand holding and they help you organize things. And then when you get to adult medicine, they're like, good luck, you're on your own. And so I met an amazing and charismatic mentor who was a Med-Peds trained physician, and she had a passion for transitional care. And so the truth was, I could be a pediatrician and prepare and train my patients and their parents to move them to the next step. But as a Med-Peds doc, I could be on both ends of that transaction. So I could train you to be better equipped to be an adult patient, but I also could be your doctor on the other side of that. And so I guess from the beginning, avoiding gaps has been something that I'm really passionate about. And so I thought I could pick one or the other, but if I pick both, I would meet patients who weren't prepared on the front end and I could help them, or I could meet patients who I'm preparing to go elsewhere on the back end. And so it was a nice combination and an opportunity to address kind of chronic problems and things that take a lot more time to address.
You brought up a good point to me that day. We were talking about the practice and some things we're doing. And you brought up an interesting point about preparatory visits. And I want you to kind of explain that a little bit because I do pediatrics, not like you. But for me, when you said it, I was like, oh, you've got a really good point there. Can you walk everybody through what a preparatory visit is and why that matters and how your pediatric training kind of led to this better practice that we frankly adopted across the entire Bespoke Concierge MD?
Sure. So in pediatrics, there's a concept called anticipatory guidance. And what that means is when you come in for a visit today, we talk to you about what's happening now, but we also then talk to you about what to expect. So we give you preparation so you can be aware of what's going to come. It decreases anxiety significantly. And if something is wrong, you'll have a better sense of it. So what we would do when I was a resident in pediatrics, when you come in for your 4-month visit, we do the visit, we talk to the mom and dad, and we give them the info sheet from the program the blueprint program that kind of says at 4 months, your child should be eating this. They should be doing, maybe not sticking forks in electric sockets yet, but whatever fun things your kids are doing.
That's for next visit, right?
Right. That's the next one. And so that was my whole point. So people would come in and I would prep them for that visit. But then all humans are unique. And so you do see some change, some differences. So if I tell you at 4 months, this is what you need, well, maybe you have the super precocious kid that's at the 8-month level and they're doing these things that aren't on the sheet of paper I gave you. And it creates this extra anxiety. And so what I started doing was when you would come for your 4-month visit, I would give you the sheet that tells you what to expect at 4 months, but I would also give you the sheet for what to expect at 6 months. So if your child happened to meet any milestones early, you can kind of read ahead and be like, okay, it's okay. It's okay. And so one of the things that I noticed when it comes to anticipatory guidance is we prepare the parents to take care of their kids. And, as you're going through your life phases, you're in school, you're in college, but it's like suddenly when you get to be an adult, they don't really tell you much, right? Like come in every year, get an annual, get STD testing, whatever, but like nobody tells you what to expect next. And so since there's such a tremendous gap in midlife women's health, and honestly, there's so many changes happening,
Yeah.
everyone is struggling. And as I talk to patients, talk to friends, everybody's like, nobody told me what is happening right now. And so I really felt passionate about making sure that people are educated and aware about what to expect. So when I think of midlife health, which many would say maybe is 40 to 65, women in their 30s should know what to expect. So if they happen to be reaching these milestones early, they're not panicking and thinking like my body's breaking down, what is going on, but knowing what to expect. And I think a huge part of being healthy, sane, a good contributor to your family, your community, everything is just feeling comfortable in your skin. And if you feel like your body's betraying you or you don't know what's happening at all times, it's very unsettling and it makes it hard to accomplish anything else that you have on your list in life.
Totally. Perimenopause, famously happens in the 30s, right? So
Right.
women start missing periods and, it starts becoming a challenge and you're not quite sure. So no, I totally get it. And I think it's extremely insightful and really valuable. It's one of the reasons we've adopted it now and brought the entire practice. So you did Med-Peds and now you're really, covering the whole spectrum. And then that led you to get an MPH, Master's in Public Health. Help me understand the value proposition of doing that after becoming a really well-credentialed physician. What's the point of getting an MPH and why do you focus on health literacy?
I think that while taking care of individual patients is really important, I also wanted to have the opportunity to have a broader impact. And so for me, as I looked at different options, a master's in public health would give me broader training in taking care of larger populations. And I chose health literacy specifically because all through my training, like I said, I'm giving out like the 4 months worksheet, the 6-month worksheet. Like if you meet with me, like you're not leaving without a piece of paper. That's just how I'm built. Like you're not going to forget what I said. I will say, okay, well, we talked about this. If you have to go home and tell your granny what we talked about, what did I say? So I have people teach it back to me. But let's be honest, we're all busy. We're living in a poppin' like popcorn world. By the time you get to the parking lot, if you can find your car, you literally don't remember what I just told you. So I want people to have tools to help them. And one of the challenges, a lot of places tools don't exist. A lot of times the tools are written at a level that is above what the patients understand. I mean, I went to, I don't know, the 28th grade or something like that. But like we can't assume that every patient we care for has that level of education. They didn't all go to medical school. And so for me, it was really important for people to understand. I had a really impacting experience when I was a first year med student. So you start med school and you get in and you're like, oh, you talk to your family like, oh, we're learning about this and people got a brain problem. Like we got small words. And then, we pay all that money. So we get the $1 million words. And so, but we're still learning them when we're a medical student. And a very good friend of mine was having a baby and she had talked to her doctor who said that I could come and be in the delivery room, which is a very big deal when you've been a medical student for like 2 whole months. And so I get in there and, so he said I could help and, I'm all gloved up and whatever. So the baby's coming out and he says occiput. And I'm like, okay. So I'm still standing there and he starts shouting. And I'm just like, it's like speaking to someone who speaks Spanish or Italian. Shouting louder doesn't help them understand if they don't understand. So finally he comes over and he puts my hand on the back of the baby's head. The occiput is the bone at the back. I hadn't learned that yet in my big word class and I didn't know what that meant. So he was irritated with me because I didn't understand him. But I did put my hand in the right place and the baby came out and she's an amazing lady who's like 30 years old now. But that being said, in that moment, I realized the gap from being on the other side of medical training versus kind of understanding the big words. Well, fast forward like 9 months later and I had big words. And then I'd go home and people would ask me questions and I would use big words and they would squint at me like, what are you even talking about? And so it was weird, like how quickly we cross over from one side to the next. And I realized not only did people not understand what I was saying to them, they were like, but what does it mean? Like, what do I do? And so that's when I realized that having a better grasp on health literacy besides saying to doctors, like, you guys got to do better, because that's where I started. And then by the end, I was like, yeah, now I'm just teaching patient assertiveness training and teaching them to not back down if they don't understand what's happening. But I really felt like health literacy and studying that was a great way to meet in the middle. I better knew how to communicate with my colleagues, how they should communicate with their patients, but I better knew how to help patients ask good questions. Because again, not knowing what the occiput was and him shouting louder and louder didn't actually help us accomplish the goal, right?
I have to tell you, before I started medical school, I had an inkling of what to expect. And so I got a book on Latin. And it was a Latin translation for medicine. And I learned that itis just meant inflammation of. And I learned because before I went to big word school, I was like, let me break this down because I don't want to learn another language. And, I'm blessed to be able to speak a couple languages. And I always list medicine as one of my languages because
that's exactly what it is.
It is
100%.
Yeah, no. And I've always made a focus of my career to try and break things down and make it a little simpler and easier to understand and make it relatable. Otherwise, all big words does is tell people that they have a big bill coming next, right? And that's been my experience. So I'm like, let's just
and it creates barriers, right?
Totally.
Because it becomes you're smarter than me. So now if you have a question, you won't ask because you feel like I'm so far away. You don't want to look bad. You don't want to feel uncomfortable. So one of the things that I always teach my trainees is at the end of any encounter, don't say, did you understand or anything like that. Just say, well, what did we talk about today? I started adopting that because I think that's so much better. I'm always one of those guys like, can you help me? Did you get this? Did this make sense? And people will say, I get it, even if they have no idea. They're going to go home and Google it, phone 7 friends. Like, my doctor, I'm literally in a million groups where people are crowdsourcing. My doctor told me this. Does anybody know what it means? Yeah. Is this crazy drug dosing? It seems weird. But you were in the room with that person for however long and you left
smiling and nodding.
And then they're like, did you understand? Oh, yeah, sure. Let me go home and call Dr. Google because they might help. And so, again, just trying to make those encounters more real and give people the opportunity to really tell, and I tell people, sometimes I use big words, sometimes I talk fast, most of the time I talk fast. But that being said, I am here to help you. So please stop me and please ask me. I'm not offended. And I don't think that there's such thing as a dumb question. So if I present something in a way that doesn't quite hit home for you, you are welcome to ask me to explain it another way. That's why I'm here. If you are in the room with me and we talk and you leave and you have no idea what just happened, we have both wasted our time. And that is not what I came here to do. I want you to leave feeling comfortable, aware, knowing what to expect, and knowing what you need to do to maximize and optimize your health.
I think that's probably the biggest thing that I get from all the physicians that work with us is all of us want to feel like we're impacting our patient's health, right? You're Absolutely. No different. I actually, because of you, after you explain this back to me, what you learned, I've actually called it bubblegum medicine because it's easy. You can chew it. You don't have to have a refined palate to appreciate bubblegum.
Right.
And have I given them bubblegum medicine today or am I trying to give them a nice filet mignon?
Right.
I do not want to fill them up on a steak that they're not going to appreciate. Let's just get some bubblegum medicine in the fold and then we'll go from there. So, all right. So that leads me to the real question is what really pulled you specifically into women's health? Because you have this fascinating background from pediatrics to adult medicine to everything in between and the occiput. But what really what drove you to that specific area to really focus on?
So I think for me, one of the things that I've always been passionate about is cheering for the underdog. And so when
Are women an underdog in this country?
Oh, no, but let me explain why and how. So that perspective or that initial approach was much that I've been in many places and spaces where I've been the underdog. And sometimes you need a boost, you need someone to help you. And in my training, I really have always worked with underserved communities. So communities of color. So when I was doing my work with health literacy, diabetes prevention, all of that, I worked with Native American communities, African American communities, Latino communities. And so that was kind of where my initial focus was in my work. And I was really intentional about that. And then I had a transition in my career and I had an opportunity to work at the VA. And very quickly, I realized that women were I'm not saying that communities of color were not underserved, but women were wildly underserved in that particular setting.
Is that the moment you basically realized that this is like a horrendously big gap?
Oh, absolutely. I mean, even when I was doing health literacy work, I was doing work related to breast cancer for several years and kind of saw it as a specific niche. But when I went into the VA system in that particular setting, I saw that globally, it wasn't just a breast cancer gap, right?
Yeah.
But I realized that there were gaps everywhere and they weren't always recognized. And while the patients felt overlooked and like the underdog and they needed some support, that the larger system didn't necessarily recognize or prioritize that in the way that I felt was right.
Would you say that time at the VA shaped your perspective, or where did you get to the point where you felt like really powerfully motivated about this?
I would say it was my time at the VA because I would see wide, flagrant gaps. I would see things that honestly, my summary, unacceptable. I kept seeing things where the male veterans could come in and get different services, and the women had to like be outsourced and go to another doctor. So women were going to 4 doctors outside of the VA to get care that a male veteran could walk in the door and get everything he needed under one roof. And they were frustrated and they felt dismissed. And they talked about how, like, this is crap and everybody's running us around. Like, nobody cares about us. We come in for appointments and they call us Mr. without ever looking at our first name on the paper. That happened all the time. Or, oh, are you the veteran's husband? Like, to this day, that happens.
Are you serious?
Oh, 100%. 100%.
Ugh.
And so, like, there were all kinds of campaigns that say she wore boots too. If a woman was seen in the VA, the assumption was she was a veteran's wife. If she's calling for an appointment, they would look at the last name and say Mr. And they wouldn't even check. If her first name was Phyllis or Felicia, she's probably not a Mr. Obviously, there's a lot of confusion, but like there were really a lot of challenges. So from the beginning, even scheduling an appointment, they felt dismissed. And then when you go into the clinic and the whole building is full of whatever, and the women's health clinic is in this back hallway that's like converted from something else, it kind of looks like it's an afterthought. And so, I mean, one of the things I really fought for and I'm really proud of is that now there's a women's health center there. So they have their own building and it's new and it's beautiful. There's a mobile clinic where we can have mammography and DEXA scans and things like that. But they literally felt and verbalized on a regular basis that they felt like an afterthought. So are they the underdog? Absolutely not. Women run the world. But in that space, they didn't have what they need to feel empowered and move forward.
And you ran several programs at the VA, at MEPS. Can you walk me through that a little bit? So when did you take over from that point to when you took over? Was that what led you to becoming, or establishing the women's health programs at the VA? What was the...
Yeah, so I mean, I think I would say that the experience I had with women's health and breast care when I was at the University of Nebraska really led me to prioritize women's health differently. And then being tasked with being the medical director for women's health and basically looking to the left, to the right, up and down and seeing gaps. Like my whole job was like, slaying dragons and figuring out how to get these things done. So even when it comes to like the lab and they were talking about testing for gonorrhea and chlamydia, well, then they came out with urine-based testing. And the data clearly shows those tests are more effective in men than women as far as how sensitive they are. But the lab had already decided that they were going to get rid of the, pelvic exam swabs and just go to urine-based testing. So like I literally remember sitting in a room with like 40 people. The whole entire lab department was there.
Yeah.
The chief of the lab was there. And he was saying to me, well, this is an acceptable test. I said, it's great for men. It's not the best for women. And I said, the literature clearly shows X, Y, and Z. And he said to me, well, I'd like to see some real evidence because, I know in internal medicine, you all have a lot of anecdotal evidence. Like it was wild.
The lab director
in a room with like 30 people said this to me and said, well, so we're not going to do that. But if you can get me some evidence, I'm like, I've seen the recent studies. I can't cite them for you, but like I've been to meetings in the last 2 months and I've seen the recent studies. And he was just like, yeah. So it was this kind of humoring thing, which I mean, he's humoring me and I'm a whole doctor. So imagine what the patients are feeling like.
Yeah.
And so when we get done with that meeting, I go back and I find the studies I was looking for and they were actually more robust than I expected. So I'm like, takes one to know one, like we can play. So like literally, I'm like, you invited 30 people to this meeting. I don't know who's who. I hit reply to all. And I was like, dear Dr. So-and-so, here's the study that involves like 50,000 people cited in so-and-so, a journal with an impact factor of such and such, which some might be considering to be fairly reputable journal. And in this journal, the summary line is X. I would like to see this test is implemented by date X. Crickets. He didn't answer, but all of a sudden things were moving around. But like, the fact that I even had to fight that hard and, he tried to embarrass me in front of people. But like every discipline I went to was like, oh, we only give out 5 tests at a time because you guys don't do them enough. They expire. I'm like, I run a whole women's health clinic and we see 40 patients a day. Why can I only get 3 STD tests at a time and have to keep walking back here?
Yeah.
And then you get the other disciplines that are like, oh, well, I mean, I guess we can see your patients. And the concerns of women veterans are different than those of male veterans. And so trying to educate our colleagues to understand the patients really became something that I realized was not a knee-jerk thing. Like I really had to do the work. So I think my passion for women's health really bubbled up in that space when suddenly I didn't realize when I went there, but my whole job was literally slaying dragons and trying to get the lab to cooperate and the radiology to cooperate. And how come they have to go outside for mammograms? Like, can't we just get mammography in-house? I was thrilled when we had our grand opening and we cut the ribbons on mammography being in the building and then not having to go to one of 7 other healthcare providers and we couldn't find their reports. And like, there's a whole person hired just to track down reports from everywhere else on the planet because we couldn't do mammograms in-house. And I just feel like women veterans deserve better, but women deserve better. And in that space, I intentionally, like, I was forced to be, and it was not reluctantly. I became like a staunch advocate and dragon slayer for the health of women because I realized, like, if I didn't speak up for them, no matter how loud they spoke, like, who was going to do it?
We were at lunch yesterday and you made a comment to me that really like took me back. And you said, after you went to Harvard, right, you did their women's health program a couple weeks back, which we will get into in a bit. But you said that women have been getting a raw deal for decades.
Oh, for sure.
Yeah. So I want you to kind of elaborate on that because like it took me back. I was like, wait, what? Like I didn't think, because in my mind, menopause was this like, pardon my ignorance here, but it was like this 15-minute thing that women dealt with for like a year or two. Like I remember watching my mom suffer through it. And in retrospect, I realized that lasted literally my entire childhood, as opposed to, you know, from like 7 until I was, you know, 18, 19, 20 years old. I remember now like the hot flashes and some of the irritability and some of the other issues. And like the framing I had as a child and as a teenager was like, oh, this is just a thing women deal with. And that's like just part of life. Like, you know, and anyway, help me understand the raw deal.
Yeah. So, I mean, I think one of the things I could say is that like in the world of women's health, there are already gaps. And there was certainly data that came out that was not well interpreted that suggested that any kind of hormonal therapy during menopause.
The Women's Health Initiative.
The WHIS Women's Health. Yes. And so basically it kind of gave, it almost put a black box on anything hormone related, right? So then even when I was in medical school, it was kind of like when people get to this stage in their life, the drugs we have are dangerous, nothing to discuss. Like that was the whole lecture.
In residency, if you give somebody this, they're going to get cancer.
Yes.
How could you do this to them? And I'm like, okay.
So like it was black box. Like we didn't even learn, right? Yeah. And so now that the data has been reevaluated.
And give people some context. Like black box warning means.
Yeah. So I mean, I initially thought about it as in residency, we were told if you give this to someone, you will hurt them. And the first thing we learned when we got in these doors is first do no harm. So 100% of the time across the board, the risks outweigh the benefits. You have no business thinking about this or discussing it. That's kind of how it's presented.
But a black box warning in particular.
Oh, yeah. Like, black box warning is when they write, you know, on the medication package, like these are all the bad things that will happen to you. You know, your eyes will fall out, whatever. But it's really the most concerning types of drugs or the drugs with the highest risk do get a black box literally printed on the packaging that alerts the patient to all of these very dangerous things that'll happen if you take this on. They may happen, they may not, but it's dangerous enough that instead of the usual side effects, you know, fold out we all get from every drug, there's this extra stamp on the outside of the package like red alert, red alert. And so the patients are panicked, but once they tell you the drug has a black box warning, it's not something you're going to just go around giving to everybody, right?
You start to hesitate. You're discouraged. Yeah. It's kind of like the smoking causes cancer on the cigarette labels. Big giant lettering like, hey, this is going to kill you.
Right.
So with the black box warning, recently the HHS, the Health and Human Services Secretary, they took away that black box warning.
Absolutely. And that was amazing. And, you know, you mentioned Harvard, and that was an amazing experience for me. That was a new game changer in my career trajectory and the work and the way that I want to do the work I do. And at that meeting, I literally met and got my pictures taken with like the heroes and sheroes of midlife women's health, including folks who sat in the FDA hearings and fought to have those black box warnings removed. And so understanding that if we look at the data a bit differently and not looking at people 35 to 95 as the same group, but really assessing it different, some of those conversations about cancer risk and heart disease risk and other things look really different. And it turns out that these drugs are much safer, like, you know, hormone replacement is much safer than we have been led to believe in the past. And like you mentioned that the symptoms last long. I mean, I remember when the studies came out that were like, hi, so the average for menopausal symptoms is 4 years, but it actually lasts from like 7 to 14 years. And everybody's like, oh, this whole thing lasts 15 minutes. Like, we'll get you a fan and you'll be fine. And that's not what people are struggling through. And the symptoms are much more than just hot flashes. So we didn't learn in depth what patients are experiencing, but we were basically told we don't have any way to help them anyway. That's not dangerous. And so it like literally it's a thing, and you know, it's a thing that just is in the ether. And as you mentioned with that study was several decades ago. But when that data came out, I was in training. And so when I should learn how to deal with this thing, nobody would talk about it. And so, I mean, for me, now that the black box warning's been removed, we're looking at the data differently. We're realizing that we have mad catching up to do. Like, there's so many people who are struggling. And even as clinicians, we're learning, right? That's why I went to Harvard to learn, because I know I have to know better and do better for the patients. But a lot of people really don't know what to do. I mean, I talk to patients who are like, I talked to my PCP and they're like, nope, not talking about it.
Yeah.
And so we want to do better for our patients.
Totally. So actually, for those patients out there watching, I actually did a whole breakdown based on what you were telling me. I did a whole breakdown on women's health, the initiative, the study, and how it's been disproven now. I cited all the studies. So if anybody wants to do a deep dive on that, we'll link it.
Okay.
Help me understand now with things. I mean, I would say that things are moving in the right direction.
Yes.
There's so much attention on this now in the last couple of years. You see CES, the Consumer Electronics Show. I was just there this past January, and they had a huge, femtech was the buzzword. And,
absolutely.
This year we're going to the SHRM conference, and Oprah's the keynote speaker talking about, menopause and everything else. Where is the system failing women most right now today, though? We're making strides for sure, but where do you think the biggest gaps are still?
The two that come to mind are that anticipatory guidance. So women don't know what to expect for themselves in their own bodies. They don't know their family history necessarily related to menopause. They don't know what to expect. And we in the healthcare space are not preparing them to understand what's happening. In that same space, I think we are also not prepared to address their concerns. So the number of women that basically are dealing with gaslighting, the averages in the research studies we see are saying women are going to 5 to 7 doctors to get answers. Now everybody's going on Google Chat GPT and doing these online clinics, and some are okay, but maybe some aren't. But nonetheless, they go there because somebody listens to them.
Yeah.
So going to your doctor and having them say, oh, well, you're just that age. Like, I mean, you just got to sweat for the next decade. I don't know, get a fan, that kind of thing. Or women go in with concentration and focus problems, sleep problems, and everybody's like, oh, you're just depressed and overwhelmed. Like, go to yoga, here's an antidepressant. And those women would benefit from hormone replacement therapy, and they don't need an antidepressant. But being kind of dissed and dismissed when you're bringing, when your whole life feels like your body is betraying you and things are going wrong, and literally the questions are like, is it just me? Am I going crazy? What is happening now? When a huge chunk of the population is trying to figure out if they're going crazy, like the universe is failing them. And so I feel like education for women, education for the planet, right? Like if you work in a space and you need a fan and everybody looks at you sideways, whatever the situation is, the universe is not well educated about this topic. Women aren't educated. Their healthcare providers aren't well educated. So nobody knows what to expect. And we're all reacting. Nobody's being proactive about okay, you're in your 30s. These are things to expect. Let's get your hormones so we have a baseline. When did your mother go through menopause? Let's figure out what your osteoporosis risk is. We wait for you to show up with symptoms, and then we chase symptoms versus helping you have comprehensive total body wellness into the next several decades.
Healthcare, that's one of the reasons we started Bespoke, actually, Dr. Addy and I. So healthcare, in my opinion, has been very reactive.
100%.
And which, frankly, is bullshit. But we've tried to take a very proactive stance, and we've always tried to push. And even myself, I find myself with these huge blind spots about menopause care, and we're making the effort to really incorporate. That's the whole point of you taking the role you have, which, like I said, we'll get into. Help me understand one thing, though. A lot of times, and you've kind of touched on this, but women are being told XYZ is normal, but it's clearly not normal.
Right.
Yeah. What do you think is the biggest thing that women are being told that is normal? And, you have hot flashes, get a fan, right? But what do you think is the biggest thing that is just not normal that they're being told to just accept? You said they were gaslit, and I think that's actually fair now. I didn't understand it until, we've done the deep dive on the research together. But
no, I think I would say that, sure, hot flashes, and that's something that's that's pretty common and people talk about it. But there are a lot of other symptoms as well that are related to menopause. So concentration, focus, memory, that's huge. I think fatigue, feeling overwhelmed. And I think...
Isn't that part of aging though?
So everybody could say it was part of aging, but they're also actual symptoms that are part of hormone deficiencies. If you had a thyroid problem and you were feeling tired, I wouldn't tell you to get over it. I would get you some thyroid replacement.
Yeah.
Right. And so I think people can have those symptoms for lots of reasons, but most women are finding that when they go in, nobody checks any labs, nobody checks if anything's wrong. They're like, look, you're getting older, get over it. you're busy, you're tired, you don't sleep enough. And I think one of the really big challenges is that all of this happens and it coincides or collides with the part of life where, like, from a career standpoint, we're leveling up, we're in these high leadership jobs, we have kids, and our kids are teens, tweens, or whatever, running with scissors. Then we may be in the space where we're taking care of our parents, we're involved in the community, so the demands on us are going up, and what our body used to be providing us when it comes to hormones is going down. So you need more, and suddenly your body is providing you with less.
I read a study recently that talked about ADHD is more common in women, but it's not diagnosed early because they typically are able to handle, they've got better coping mechanisms. But as they get older and they have the challenge of the career, the children, the parents are taking care of their marriages, so forth, so on. And then the hormones are starting to
cracks start to show.
Cracks start to show, and that's when they're getting diagnosed, even though it's been there since childhood.
Yes.
So,
and I literally have had many conversations with women who were like, and they're like, women are amazing beings. Let me just say that. But like literally the way that we work around things and work around challenges and create all these mechanisms, we don't realize we're working 3 times as hard to get half as far until midlife and the increasing demands. And the number of women I've spoken to who are like, my teenage child just got diagnosed with ADHD. And after filling out all those forms, I've been like that since I was 8. I didn't even know. And so then they're able to get assessed and evaluated and find out what's the best thing for them on their path. But this whole time they've been churning, running for decades and decades. But again, midlife is not just the hormone changes, but like the social, community, family expectations, the things that are expected of you in the workspace everything is hitting a peak at the same time. Like I said, what's needed of you is up, and what you've got, your reserves are down. And so then, the cracks start to show, and those great mechanisms for working around challenges sometimes are just no longer enough.
So we talked, it's super helpful. And I know you're doing a video if you haven't already. I think you've done a video on ADHD and women, and
yes.
we'll link that when it goes live.
Yeah, no, it's all done.
Help me understand something. So menopause is getting a lot of attention now.
Yes.
And as a CEO of Bespoke, I recognize that a lot of it has more to do with the market share.
Yes.
Not necessarily actually doing really profound or really good work.
Sure.
But by the same token, I still feel like menopause is treated like a side conversation. And it's not really treated as this impactful thing that people are living with now. I've talked to other husbands, and I've asked them about this just to kind of do my own research, because you've really
I've been secret shopper queen.
Yeah, you've helped enlighten me a little bit, and all of them kind of look at me and they go, "Okay, we just it's cool, man. I'm married. We don't talk about that." I'm like, "You don't talk about it? What do you mean you don't talk about it? They want to talk about it at all? No. What do? I leave." I was like, "What? I go away." And I'm like, "You go away?" Or I buy chocolates. And I'm like, "Get out of here." Or flowers. Or I heard a whole series of things. And I'm like, "You never have a conversation about, do you talk about end of life care?" They're like, "No, I don't talk about that either." I'm like, "What do you talk to your wife about?" It's been a thing. So now I've started asking my wife about that. And she looked at me and she literally gave me a list of things her mother went through at the ages she went through. And I had no idea this was so prevalent on her mind. We're still having children. Like, we're still considering maybe one more. And she's like already going, "Well, my mom had it at this age. And I've got that year circled on my calendar." I'm like, "Are you serious?" Like, it's just not in any way the way I think. So
yeah, and I think the truth is, because people aren't aware and we're not comfortable. I mean, I can go back in my life and say, like, whenever they had those classes, your parents had to sign, could you go listen or not? And then your parents sign no, and they're like, "I'll just tell you." And then you have the talk and you're like, "I don't know what's happening here." And then you're like with me at the 600s in the Dewey Decimal System in the library, like trying to read books because you still don't understand what's happening. And so I think that there are a lot of topics like that are super taboo, and we're not prepared. And I think we're now at a space and a place where this generation of women does not plan to stay silent, and we want answers, right? We want to live our best lives. And to do that, we need our partners to understand us better. We need our workspaces to understand us better. But the truth is, yes, people don't understand. They either run away or they buy you chocolate and they're like, "Good luck with that." But the truth is, that's not how
depends on the chocolate. I think it depends on the chocolate.
You're hilarious. But I think that's how it's been going around. And so I think the truth is that doesn't work, or it doesn't work anymore.
I will tell you. So this is kind of a 2-part question I have for you is, what do women and men most misunderstand about menopause? From what my research has shown me, my anecdotal research, even though I'm not internal medicine.
You're funny.
Yeah. But for the men I've talked to, they're scared to ask And it's like this, I always joke when my wife and I go on vacation with our kids, I get my hot girlfriend back because the kids aren't like hanging on her and she actually can sleep through the whole night. And she actually is interested in me again. I'm like, oh, I've got some bandwidth for you now. And it's amazing. But when I've talked about menopause, most of the guys are like, yeah, I just remember what my wife was like. And I know it's not like that now.
Right.
And it's almost like I don't want to ask.
Right.
And that's been the universal feedback I've gotten. It's kind of bewildering. And so for most men, the one thing I want you all to understand, it's probably better to talk to your wife about these changes.
Oh, 100%.
Yeah. It was shocking to me, even though we're not at that phase
Sure.
yet. I'm worried about it. She was shocked I even knew about it.
Right.
And it's one of those things. But what do you think women misunderstand about it now? What do you think is kind of the key thing that you want them to get?
I think women, because of like all the medical gaslighting and challenges we have being heard in the healthcare space, I think women accept being dismissed too easily. Even if they're going to 6, 7 people before they get an answer, a lot of women don't go to 6 or 7. They'll give up after 1 or 2.
Yeah.
And so I think, this is a normal part of life. You are not losing your mind. There are answers, there is help, but you have to engage in the dialogue. And I think demanding to be heard is something that we all have to learn to do for ourselves. In the future, the system should work better so that you don't have to fight so hard. But like literally, I did a webinar last week and we talked about menopause and perimenopause, and it was amazing. I had 50-something people sign up instead of the 5 I was hoping for. And we had really good, robust conversations. And the things that people brought up, hot flashes, brain fog, mood stuff, but even like other like urinary things, incontinence or sexual problems or whatever, they were like, yeah, I talked to my doctor and they were like, oh, like blank face.
There's a great book I read called by Malcolm Gladwell.
Okay.
And he talked about all the little advantages that lead to the big successes. And one of them he talked about was a sense of entitlement.
Yes.
And I was taken aback. I'm like, entitlement. I don't want my kids being entitled. I don't want to be entitled.
Right.
And it talked about how some people grow up in feeling entitled to good health.
Yes.
Feeling entitled to answers to their questions. And if you have that sense of entitlement, you will not get such a raw deal when you're in front of a doctor, when you're in front of a judge, when you're in front of some other authority
because you're
figure.
not leaving without what you came for.
Totally. And so I think, I'll see if I can remember that book.
It's not Tipping Point.
It's not Tipping Point, but it would relate it to Tipping Point.
Okay.
But it was the key premise was that all these little advantages really impact the quality of your children's life. I'm very focused on trying to support my kids. And but that sense of entitlement, I always had a negative connotation. But just with what you just said, I really think
we have to expect better and force the people around us to do better. Absolutely. Be it our doctors, our partners, our coworkers. Like, we're not leaving without what we came for. And getting less than that, being treated poorly and being dismissed, like, we're done with that. And I think I do need the women who are within the sound of my voice, our patients for Bespoke, to understand, like, when you come here, that's what we expect. We want you to not leave without getting what you came for, and we are prepared to give it to you. And I think even if you don't come to Bespoke and you're staying with us to learn and grow and do better on your journey, that's what you should take with you into any setting that you're in. And I think women misunderstand or are not understanding that they should be more entitled to the best that can be out there for them. Yeah. And so, like, we have to have that. And as far as what the men misunderstand, there are not conversations. It's like you said, like, put your head down and run away. But I think those things are really real. And I think if you're in a space when you literally are having the highest demands on your life, professionally, personally, etc., but then you feel like your body's completely betraying you or you might be going crazy, and the person closest to you is just running away, that also adds an additional stressor or burden. And so even if it's awkward or it's hard, I think the message should be, I don't understand this. I don't know if you understand, but I don't understand this. I will sit with you while you sit with it. Like, I am here, whatever is happening, and we figure it out together versus like, I'm going to let you sort it out alone and like get back to me when everything is cool. Because again, I mean, the stats clearly show women spent 40% of their lives in menopause. And like I've told you repeatedly, anything that was affecting men for half of their lives, there would be better research, better care, and people wouldn't be running away. Everyone would know what to do and expect. And so when it comes to women's health, midlife health, it's a new day. We're not leaving without what we came for, and the revolution will be televised.
I would posit that that's not by design. I would actually say it's because of our as in men, our own ignorance and our own fear, that's how it led to this position. I don't think I don't think the healthcare system was designed by men to hold women back or keep them down.
No, but
Yeah.
they were left out. The research
Yes.
studies don't include us.
Without-
Like
yeah.
all these things leave us out, whether it was in like, so ascribing no intention or malfeasance, the situation still exists, right? Like,
Yeah.
like half of the population on this planet, like we got questions, no one's got answers, nobody's ever studied it. And so anything we want is you got to sign 1,100 forms for us to try to help you because nobody studied this. I don't know if it's safe or not. And I mean, we can talk for days about all the different drugs and what's approved, not approved for men and women. But even if it wasn't intended that way, that's where we are today, right?
Yeah.
And that's why you and I are here. This is where
Totally.
it's a new day. We start better, we do better.
So you touched on this a little bit. I want to segue a little bit. You touched on this before, but there's the obvious symptoms of menopause, right? So
Right.
we've got vasomotor symptoms, which is again a big fancy words.
Like hot flashes and
We've got the hot
sweats and all that.
flashes, the sweats, the interrupted sleep. But what are the not so obvious symptoms of menopause? What are those second and third order consequences from those immediate symptoms that you see that affect, that are just part of menopause? You talked
Right.
a little bit about concentration already.
Yeah.
Yeah.
So concentration, focus, brain fog, there can be mood related issues. So if someone is prone to have depression or anxiety, the hormonal shifts can make that worse, for sure. But I think the danger or the caution for everyone listening is that anything menopause is not a mood disorder. And that's what women face, is that if they have concentration, focus, and sleep problems, they're being given antidepressants. Nobody checks their hormone levels. Nobody asks them about other symptoms. And I think that's part of why we'll talk about the Menopause Roadmap framework really soon. But that's why I built that, because I feel like when nobody knows what to do about menopause. So if I walk in and say I'm sweating at night, besides giving me a fan, they may or may not give me a treatment for that. But I've never had an experience where they deep dive and then say, okay, these are all the common symptoms of menopause. Are you having any of these? They only react to what I complain about. And so what we're trying to do is to do better. So things that people miss, I would say, issues related to incontinence, sexual dysfunction, all these things that are basically estrogen deficiencies. People don't talk about those. And so the stats clearly show like 85% of women struggle with symptoms in those categories and are not receiving treatment. And the doctors don't ask.
I was stunned when you told about urinary incontinence responding to estrogen.
Yeah, and they're just like, oh, well, you had a baby and you laughed and you sneezed and there it was. So everybody go get poise pads. I remember the day I was in Walgreens 4 aisles over and I heard this lady talking at the top of her lungs on her phone. And I really, like we said, people don't talk about these things. So I figure when things are bothering folks enough that they talk at the top of their lungs in the hearing of strangers, like it's very much bothering them. And she's like, when I have to go, I have to go. But the hilarious thing was she was literally standing in the poise pad aisle. And I was like so mortified. Even if it was me, I'd buy my poise pads and slide on out.
Yeah.
And hope that the cashier was not a dude and get on out of there. So for her to be shouting at the top of her lungs in Walgreens, I was like, wow, these things are like actually affecting people to the point that they're like shouting on the phone while they're shopping. So I think those are things that people are often not aware of. I think things that are longer term risk is having less estrogen affects cardiovascular health, risk of heart attack and stroke. It affects bone density. So osteoporosis is a really big issue. And then honestly, brain health. So as we're talking about like mood stuff and concentration and focus, we get folks saying, oh Lord, I have dementia. Like what's going on? I can't remember. I used to be able to keep track of everything without a notepad. But in truth, estrogen deficiency is related long-term to decrease in cognitive function, plus or minus dementia in the future. And so I feel like one of the things that I really learned when I went to Harvard was that in my experience, we were giving people hormones enough to treat their symptoms, like so they didn't need a fan all the time. Right. So it's like if you stop sweating, like we're cool and we're done.
Band-Aid.
Right. 100% a Band-Aid, because the truth is those deficiencies are related to long-term things that'll affect you in the decades ahead. So you might feel fine. Your hot flashes might be well controlled. That doesn't mean you're not going to have osteoporosis and bone fractures in the next 15 or 20 years. That doesn't mean that you're not going to have an increased risk of heart disease. That doesn't mean you're not going to have an increased risk of cognitive difficulties or dementia. So treating just the symptoms is not enough. It's a Band-Aid. But let's be honest, it's been a fight to just get that far in the face of all the black box warnings and the honestly, like we said, we weren't trained to do this. And so we literally have to go back and be intentional about retraining ourselves so we can do better for our patients than just saying, oh, you're at that age. Oh, I'm sorry it's happening. Like every year you go in and your doctor writes down still having hot flashes for 14 years. Like that's the best we got. But honestly, those symptoms are related to those cardiovascular risks as well. So it's not even just we're treating for convenience. We need to see this as long-term
foundational
health.
It's absolutely foundational. So I talked about Caitlin earlier. She's 36. We're still having children, or at least in that phase. Why would somebody in her 30s care about this? I know those risks. You know those risks.
Right.
You've been really great about educating the public. But why should somebody in their early 30s, clearly in the throes of having kids,
Right.
or even in their 20s, should they care about this? Should they care about hormone replacement, or even just be aware of it? Or is this something that they'll worry about when they start hitting menopause? Like, why should anybody care in their 20s and 30s?
I think because it's worth knowing, right? Anticipatory guidance. Same if you bring your kids into pediatrics and nobody teaches you anything and all these things are happening around you in front of you and you're always in catch-up mode, you can't do the best you can do, but you also have this additional level of stress. And I think that if women in their 20s and 30s know that this is a thing, they would be more likely to have conversations with their doctors, with their friends. Like, menopause is a team sport. It ends up being that way. Like, you need your doctor on your team. But let's be honest, any health issues, when I'm in these rooms and people are like, my doctor stinks, they're crowdsourcing 30,000 strangers. They've been talking to their friends. They've been Googling.
But is that good? I don't think that's good for people to be crowdsourcing.
No, I don't
answers.
think so. But at
Yeah.
the end of the day, if it's a team sport, as in I have my cohort of friends and we talk about what we're experiencing, it normalizes it, right? It's not like, oh, it's just you, you're going crazy. When I got on that call and had women say, like, we did, anonymous word clouds, like, what's your biggest symptoms? And 50% of the people said hot flashes. And people are like, oh my God, I'm not alone. I think that's the part where it's a team sport. If we all are open and honest, and it's not always comfortable, but we're reasonably open and honest, when you realize it's not just you, when you realize this is coming down the line when you're 20 and 30, then when things start to crop up, you talk to your doctor earlier versus I've actually been suffering with this for 8 years. But now I'm dying, so I'm asking for help. Like, we saw slides and pictures of people who clearly not had hormone replacement therapy for like a long, long time, and they were having longer term symptoms or chronic problems that could have been treated or addressed earlier, but either they didn't know to ask, and or they went and they were told you're fine, go home. And so I think the more we have these conversations as part of like the normal discussion, the phase of life, right? Like you're saying, like you ask people, do you talk about end of life care? What are you going to talk about with child rearing? Like, it's a phase of life that should be discussed because it's real and it's such a significant portion of life. If people are aware about it, men and women, the conversation goes better. And when a woman needs help, she goes sooner and she doesn't leave until she gets real help, right? She doesn't accept the Band-Aid and just walk home.
Yeah.
And so I think the conversations early will contribute to the next generation not struggling the same way that we have.
So, and also, what's the earliest you've seen a woman go in? I know it's a little off topic, but what's the earliest you've seen a woman go into menopause?
I've seen mid to late 30s. Now, we won't count people who've had surgeries and, hysterectomies for other reasons. And so the hormone thing looks very different if you had a surgery. But I've seen mid to late 30s. And one of the things that comes up is that they didn't ever have that conversation with their mother. But like the studies show, 6 to 12 months within whenever your mother went into menopause is about what the clock looks like for you. So they never asked their mother. This whole thing is sneaking up on them. They're like crowdsourcing on Google and doing weird clinics online or, getting all kinds of pellets and pad, all kinds of things. Like, oh, there's this patch. And if you put it on, like tomorrow, you'll know your sleep problems. Okay, but nobody asked you about menopause. And so I feel like everybody's treating symptoms in isolation and not understanding this is a body-wide hormone deficiency. Like, we have to address all the symptoms, figure out what you need and get that to you versus, oh, you're not sleeping well. We can do that. Oh, you have a mood problem. We'll give you a pill. Like, instead of addressing 12 organ systems with one thing that systemically handles it, we're giving you 12 different things, each to chase one symptom. And nobody, we can give you 12 things, but none of the 12 things is something that would actually hit all 12 topics. It's 12 individual things. So everybody's running back and forth, like, I got this class and I'm going to go to, I'm meditating for this. It's kind of exhausting to need that many therapies in your whole life while looking after everybody else. And so if there's one thing that would solve, let's say even 5 of 12, that would take us so far. But again, I think we as a general public are not well educated. We as healthcare providers are fighting to do more. And I think at Bespoke, we really pride ourselves on doing that work. But that's not something happening everywhere.
That's a perfect segue to the next segment, but I want to just bring this home. The youngest patient I ever treated was 34 for menopause. And I'm so stupid, I didn't realize. I assumed it, she was in perimenopause for a year before, and I assumed it because of how hard she was working out. And so I was like, oh, this is normal. You're just missing your periods because you're working out so hard. Next thing you know, they just stopped for 6 months, got a period again, and then it stopped. And I was like, there's no way. Until we did a family history, she literally calls her mother in front of me. She's like, oh, yeah, I was 35 when it happened. And I was like, wait, what? I didn't even know it could happen that early. I thought women get a baby till they're 42, 45. Halle Berry famously with her geriatric pregnancy.
Oh, 100%.
Right. And so it really took me back. So for me, that's why I talk to my wife about it now. You can see women in their late 20s, early 30s hitting perimenopause. and then menopause. And really the data is showing you want to be starting women early and often on hormone therapy.
Correct.
You don't want to wait.
You don't have to wait until
yeah.
it's done. Whenever they start to have the symptoms, that's a good time. And it's funny because when I was preparing for that workshop last week, and the only thing I could think of when I learned about like kind of like all the hormone surges, like some just go down and some are like wild at the same time. And so I was like, the only analogy I can think of is like something electrical. So I actually did like a little research, and there's something called a loose neutral wire. The neutral wire keeps everything like working, but when, like it's basically a short in the system. So with the loose neutral wire, some lights are really bright, some are dim, some are off. And it's not consistent. Like today you walk in, the light kind of flickers. You're like, oh, that's weird. And then tomorrow the light's just on, but it's brighter. And then the next day there's no light. And so I'm like, that's exactly what's happening. Your body is like doing that thing where it's up and down and all around and you don't know what's happening. But if you're not prepared, when things start to get weird, you're like, oh, it's weird. Because we've all had the experience where you have a complaint and you go to the doctor and then you get there and it's gone. There's nothing for them to see. So you're like, oh my gosh, I feel really weird. And then you get there and you're like, fine that day. And they're like, okay. So it's like we're all chasing our tails, right? The symptoms are going up and down. Like you're living in this body that's going up and down. And then finally you get an appointment and then there's nothing to see. And they're like, okay, come back when it's bothering you. And then you make an appointment when it's bothering you. And by the time you get there, there's nothing to see, right? And so I think just, again, being aware that that's the trajectory, that up and down piece, helps patients be better able to articulate. So, I mean, when I talk to patients that have any kind of symptoms, I'm a fan of trackers. When it's bothering you, like mark it down. Even if you're fine when you get here today, like what has been your experience? How can we be ready? But again, knowing that it can happen really early and we want to start people on treatment sooner, and that if something is strange today, you should like take note, mark it down, whatever, because again, we don't want to wait till the dead stop, right? Like when you've had no periods for 12 months, well, this has been going on for anywhere from 4 to 11 years. And there are things that we can offer that don't just affect your day-to-day symptoms, but affect your long-term health and how you can optimize your performance on the planet, in your family, in the world.
No, I think it's great. And I think it's helpful. We're going to come back to that a little later. You and I have worked together now for 8 months, almost, give or take.
Let's see, started last May, almost a year.
Almost a year now. Oh, yeah.
Next month is a year.
That's right. It hasn't felt that long. It's felt like I'm learning from you every day. So it's pretty awesome. But in the last 3 months, we jointly developed this role of a Chief Women's Health Officer.
Sure.
I'd never heard of it outside of the allusion to something similar on your CV. And I didn't know that we needed it, frankly. And I want to know, for everybody out there, can you explain to me what you actually do as a Chief Women's Health Officer? Like, it's not a title, it's actually a role. And help everybody understand out there, like, what your role really is in the company now, not just concierge physician.
Sure. So, I mean, I think for me, when we were talking about what would you call this and how would you frame it, every part of it was really intentional. So I think for me, the chief piece was important because it said that to our company and to our patients, this matters. Like it's not an afterthought, right? We don't have chief medical officer, all the chiefs, and then women's health is like a thing in the corner. So elevating women's health to the level of the C-suite says this really matters to our company. Women's health is critical. And I think that we should be integrated in all of the decisions when it comes to how we're building systems and creating things. So in many ways, I consider myself an architect, right? I feel like my job in this role in this company is to create programs, systems that elevate women's health in this space and make sure that female patients have what they need. And so we can debate all day, but we both know men and women are different. And so understanding that and attending to that, because there's like, you get the group of people that don't want to say there's differences. There are differences, but ignoring them or running away and buying chocolate doesn't help, right? And so I wanted to create a space where women could come in and say, hey, these are my concerns. I feel seen, I feel heard, and I have a chance for my health to be optimized throughout the lifespan, but especially in midlife, which is currently the big black box, the big black hole.
Yeah.
But I really felt like us developing unique and creative programs that address things that the whole planet is still learning and like missing, frankly, is really important. And so I appreciate that Bespoke was willing to elevate this role to that level. But I think that it's important that we do it because people need to see it matters.
I'd like to point out as a contra, we don't have a Chief Men's Health Officer role.
But all health is men's health.
Maybe.
Most. We're not studied in the data.
That's
for
true.
so many articles.
No,
So
no, it's
different.
It's criminal.
And there
yeah.
may be a space for that down the line, but the reason I thought this was important was because of the black hole.
There were so many gaps I didn't understand until you really helped me
I
understand.
mean,
it,
I
yeah.
can roll through the Viagra data and all the other things, and we can talk about
We'll
it all day.
We'll say that for the next podcast.
All right.
All right.
But I'm letting you know it's a big gaping hole. So I think elevating it sets us above because it says that we see something that a lot of people don't yet see.
Yeah. No, I totally agree. So Dr. Eddie and I have worked really hard to build out the programs, and our focus has been trying to meet patients where they are.
Sure.
And in a unisex way. Actually, I've never thought of it as a men's health or women's health,
Sure.
but I've thought about it as like, okay, well, some patients are in the beginning stages of their adulthood, and they're quite comfortable with a direct primary care program, something
Right.
that just primary care, preventive medicine, check the boxes. I'm relatively healthy, don't want to spend a lot, but I
Right.
need to make sure I have access and things like that. And then you get to the middle ages in the 30s and 40s, and we have
Sure.
that optimal performance plan. And then for patients who are really focused on lifespan and they want to value every second of their time and want to get as much of that time back
Right.
as possible, we built that executive health program. And then for our patients that just don't accept anything less than the absolute best of everything, our bespoke tier. Walk me through how your programs that you're building nestle in and feed into those other programs, because those programs are built for everybody.
Sure.
They weren't specific to men, and they weren't exclusive of women. Women want to value their time. They want to,
Sure.
we do DNA maps on everybody, not
Right.
just men. So help me understand how, as a chief women's health officer, you've connected all the things that you're bringing to the table to those bigger plans.
Sure. So the roadmap program that we've built, the Menopause Roadmap, really is one that it meets patients where they are. And so it gives women an opportunity to choose how they want to have their health concerns addressed, right? And so I told you there are all these gaps and things that are missed and forgotten. So we've really created a program, for lack of a better word, like a curriculum. There's a program that literally, in a systematic and intentional way, touches all the topics. So it's not like, you see your PCP 3 times a year, and if you go and talk about hot flashes, the whole visit about hot flashes. Like, we can talk about hot flashes, but we still need to talk about bone health, heart health, about your skin. So we've created a really detailed program that makes sure that every patient gets a deep dive on all those topics. However, every patient has the latitude to say what they want, right? So we have folks who are like, look, I already have a doctor, I'm good to go. But I'd like to chat with you for a one-time consultation. So we've got a one and done. We've got a different pack for folks who are like, oh, I just want to talk about 1 or 2 topics, right? So that's kind of a foundational program. And you can come in and we'll get your labs and we'll, again, dived into your top 2 topics and we'll talk about that. Then we have folks who really want the more immersive experience and they want the chance to deep dive all those things. We can do them over time. If you want to do a couple visits a month, we can do them through the year. But we do have an intensive format that'll allow you literally, if you want to do all 14 visits, the Dr. Kumi dozen, 14 visits in 14 weeks, we can accommodate that, but you're going to have to work hard because you need to get your labs and everything we need, you need to get the data so that the visits go smoothly. So we allow patients, I think, the opportunity to go through all these really important topics and body systems at a pace that they're comfortable with. And so I've absolutely met people who are like, I am miserable. I need it all now. And I've met people who are like, I don't think I'm quite there. We can pace it. I'm happy to have anticipatory guidance and learn as we go. And so I think the nice thing about it is, while we have this program or curriculum, it does nestle into the programs we have, and it gives the patients the opportunity to direct traffic in some ways, right? To say what they want or need right now.
Yeah. It's funny. So I built that women's health assessment, initially exclusive of your input, or Dr. Barnes or any other physicians we have, because it seemed very obvious to me, we have to check these boxes. And then you came back from Harvard. And we went through everything. And I was like...
And it's a new day for everybody.
It was
like we all went to Harvard.
Woefully inadequate. And I thought it was a really good representation of just how many blunders I had, in my estimation, because we have a men's health parallel.
Right.
But our men's health parallel is about erectile dysfunction and about andropause and a few things that really it doesn't eviscerate the full experience. Yeah, not at all. And so our women's health assessment is like this jumping off point that I actually thought was comprehensive. Again, until you and I sat down, and then you came to me with this immersive program, which I was like, this is a lot. And I was frankly, I was skeptical. I was like, this is a lot of medicine in a really short period of time. And while a lot of that is covered especially in the executive health tier and the optimal performance tier, you made the point that people have been suffering for a long time.
Right.
They're not getting answers and they're impatient to be patients. And I
Yes.
thought that was a brilliant way to frame it. And so you built this immersive program, and we incorporated it, and we tried to build in all these really key strategic pieces. And you're
Right.
right, like you need to be on top of things, and it doesn't fit everybody.
Right.
And then we found this Goldilocks zone recently. And we figured out, we were debating this, and what's the foundational pieces here? What are the core four,
Right.
as it were, right? And you brought up some really good points. And I think it's worth kind of talking about that right now. What do you think are the core things that every woman, as they are in their not middle pause per se, but
Right.
like they're in their 30s,
Sure.
like what should they be focusing on at that point? So, we've touched a little bit on blood work, right? And so hormone tracking, I think that's
Sure.
really important. There's different ways of doing that, but what are the other three things that you think are so foundational to women's lifelong health?
I would say absolutely metabolic health and weight, right? Because
Sure.
we all are working to like eat all our Wheaties and eat all our vegetables and go to the gym. And one of the things that happens during perimenopause and menopause is women literally are like, okay, I eat 11 salads a day. I'm at the gym 5 hours a day. And like, I'm still gaining weight. What is happening? And so I think, again, being aware gives you that anticipatory guidance. But understanding that those hormone shifts affect how your, body distribution, your weight, et cetera, kind of plays out. But that being said, that's also going to affect your risk, right? For heart disease, for maybe sleep apnea. Like there are all these things that are affected by weight. And so keeping that as kind of a core is really important to make sure we address that for everyone throughout the lifespan. But for women heading into the middle of life to know that like, A, you're not going crazy. Like this is literally happening to you.
So our metabolic and hormone health,
Yes.
blood work.
Yes.
Check.
Absolutely.
What's the next one that you want?
I would say the next one that I would find critical is the brain health piece, the brain and mood. So that's actually two categories in the curriculum, but the concentration focus piece, talking to people and again, normalizing that and figuring out where they are and understanding, as we said earlier, that there are many women who are not diagnosed with ADHD until this season of life. So having those conversations, ADHD assessments is necessary. I think is also really, really important.
You told me earlier today too that the third core piece was sleep.
Yes.
And so you'd insisted that we incorporate sleep studies on every woman going
Yes.
through this core four style program. Help me understand that a little bit.
Well, I think so. Sleep changes anyhow in this season of life, right? And sleep is so multifactorial. So many things affect sleep. And so I
A
think
snoring loud partner included. So
who maybe needs a sleep study. So when you go to your doctor and you say you have problems with sleep, I'll be honest, the top three things are like, A, is it caffeine? B, are you just not going to bed early enough, too much screen time, this, that, or the other? Then you talk to women and they're like, oh, hot flashes. Or it's just like, oh, depression and anxiety affect sleep. So again, people pass out antidepressants without doing the deep dive. And I'm not saying that mood may not play a role, but it's not necessarily the only thing that affects sleep. So understanding that, yes, we want to be aware of depression, anxiety related things. We want to know about hot flashes, vasomotor symptoms. Are they waking you up at night? Are you having a lot of new anxiety? But there are also hormonal shifts that literally just affect your circadian rhythms and how you sleep. And in addition, sleep apnea may be a part of the picture. So I think when it comes to this, sleep is completely disrupted. We don't know why. But if you don't sleep well, you can't think well. So brain fog stuff is all magnified. If you have mood issues, they're all magnified. Like whatever we're talking about is worse when you don't sleep, right? We've seen the studies that say if you're sleep deprived, it's the same as driving a car impaired. So like that's huge. So if you haven't slept for talk to moms of small children who haven't slept in months to years, right? And then say for the next 20 years, you don't get a nap, like you don't get good sleep. It impacts all of your performance in every area of your life. And so for me, some people say their sleep is fine. And for them, I clap and I'm thankful. I've had my seasons of sleep disruptions and trying to get to the bottom of it and having people say, oh, you're fine. Oh, it's just this. No, we need to actually talk about what it might be instead of you dismissing me without doing the work. So if there are 5 to 7 things that impact sleep, we want to know that we've done the deep dive into all of them and that anyone we leave with, okay, so you just have primary insomnia or it's just a sleep problem. We've ruled out all the other things that actually affect sleep and done all we can to help you develop healthy habits and optimize your sleep hygiene and all of that.
So we've got lab work,
Mhm.
we've got sleep,
Yep.
we've got the focus and neurological piece. And I remember you told me you were really excited about the last one, which is bone density
Yes.
and osteoporosis preparation.
100%.
So you walk us through that, because again, my wife's 36, she's not even touching perimenopause.
Right.
And should she be worried about her bone density? Why would you consider that such a core piece of women's health?
So she shouldn't be worried, but she should be attentive. And I think that's the thing. My goal in all of this is for people to be prepared so they don't have to be worried. Because I think we get worried when we're not ready, right? Things are happening. You're like, oh Lord, am I dying? Am I going crazy? Am I losing my mind? Like maybe I have dementia. Like, because we literally have those conversations with people who are like, I'm really scared and embarrassed to ask you this, but do you think I might have dementia? And it's literally hormone related brain fog or other concentration issues. But the only thing they know is like yesterday they could think straight and suddenly everything feels weird and they're not prepared. So the only thing it could possibly be is like you're losing your whole mind. And so I think having those conversations helps people to not be worried. But I think being aware of bone health is really critical because it's a lifelong process, right? You need to exercise enough, have enough weight bearing exercises, and like there are different medications that treat lots of problems that can affect your bone density. And so being aware of if you're at risk for that reason, what's your family history, how much caffeine, do you have any history of any kind of eating disorders? Like lots of things affect bone density, but hormones do too, right? So the cells that lay down bone and the cells that clean up old bone, how fast they progress and how all that process works changes when your estrogen levels change. And so I was talking with a very good friend of mine yesterday, day before, about osteoporosis and fractures in women. And I was just like, is this a thing? Like, should we write an article? He's like, no, there's hundreds of articles. There's no reason to write this. It's really obvious. Like he said, you might find a new angle. But what they call fragility fractures, fall from standing height. Women who are quite young are having fractures, and it's related absolutely to decrease in estrogen and them not having any treatment or awareness of that. And when I meet a patient who's in her early to mid 60s, who's had multiple fractures, has never had hormone therapy, hasn't had treatment for her bones, and said, well, nobody ever told me that. Like, to me, that's like an outrage. Like we talked about, like unacceptable. Like, you'll see me with the unacceptable cloud above my head on many topics, but it's not okay. And so I think we're better to assess women early and see their bone density. The other thing about DEXA is it'll tell us things about, kind of muscle density and other things, because those are things that are important. But I think educating women about bone health, like osteoporosis is not a problem of little old ladies, right? But that's been the assumption. It's like we need to protect our bones starting now, starting yesterday. And so someone who's the age of your wife absolutely needs to be aware of her bones, not worried about them, but knowing what to do to protect her bones now and checking in on how her bones are doing over time.
And it's not all just hormones, right?
There's so many other things that go into it, but the hormones then kind of accelerate what might be happening.
So at 36, you should be doing things as a lifestyle that are going to promote bone health so that as she gets into perimenopause and menopause,
like her bones are stronger and then she's just staying aware.
There's more reserve.
Because I feel like if you are aware earlier, if something changes, that something's changed. Does that make sense? Like we can't change what we don't measure or what we don't attend to. So like now we're in a world, everybody's wearing 1100 trackers and they know how fast their heart beats when they're sleeping and stuff. So, I mean, that's fine. But if you're not keeping...
I'm one of those guys. See, I love my data.
Right. Too much data makes me nervous though. Like, then what are you going to do with it all? That's why like health literacy, what do you do? So having a lot of information you don't do anything with might be different. But in this case, I think knowing the status of your bones now, knowing what you need to do to keep them healthy, and then checking in every so often to see how you're doing is really important. So you don't have to worry. But then as you enter perimenopause, menopause, you're on the right track and you have the interventions you need to keep your bones as healthy as possible, right? So many women think that everything's fine and they don't need a bone density. There used to be a time, they won't pay for bone density unless you're this age or whatever. But they would think their bones were fine. And then you fall and break a bone, like something that should be like a bruise. Suddenly you've got a broken bone and you're 45. And now it turns out that your bones are really thin, but you never knew it. So it's a process. Like you don't wake up and just break a bone, right? So as you said, like you need that reserve. And over time, you haven't been building it, weren't aware that anything was happening. Now your bone is broken and now you're running to catch up. And, so
there's actually an equivalent for cardiovascular health that's universal, but it's VO2 max. So you should be spending your adult life, and we work with all our patients, as you know, to build up their VO2 max because they're peaking in their late 40s and their 50s. And then where you're at 50, about 35 to 40% below that is where you should be at in your 80s. Right. And that determines your ability to get around. So, that's the way I've understood it from you. Let me see if I can summarize everything you told me to make sure that I've got this correctly. So our women's health assessment.
Ooh, teach back. Look at you.
Just making sure. I want to give you.
I love that.
Yeah. Our women's health assessment is more of a jumping off point.
Yes.
It's low cost, but it's a good starting point for somebody who maybe hasn't done anything with their women's health, hasn't had any blood work done, and just needs a quick survey of what's going on.
Sure.
It's priced that way. It leads into any of our other programs.
Absolutely.
Our immersive program is much more robust.
Right.
And you get a lot of really intense attention. Ideally, you're talking about patients who want their answers now, are highly committed, and ready to go all in because they don't want to wait. And then they'll feed into any of the other programs. And at that point, it's about maintenance and maintaining.
Absolutely.
And our
Because
foundation.
this is a lifelong journey, right?
Right.
It's not a one and done. It's not a 12 and done. It's
Right.
not a Dr. Kumi does and done. Like it's a journey, and we want to walk with you.
Yeah.
And how we start depends on what you need and
Sure.
what you want. But like we intend to be in it for the long run.
Right. And then our middle program, our Goldilocks zone, as
Yes.
it were, our foundational. This is really designed for women who don't really have the bandwidth to commit to something really
Sure.
aggressive and immersive,
Right.
but need to make sure they're covering their bases.
Yes.
And they want to spend a good month and get these 4 critical pieces
Right.
dialed in,
Yes.
and then
Absolutely.
feed into one of the regular maintenance programs
Yes.
so they can keep building areas that maybe need a little bit more attention. Is that a fair summary?
That's an excellent summary because, like I
Okay.
said, the goal is for us to meet you where you are.
Yeah.
And your entrance ramp is whichever one you want it to be, but the goal is the long-term maintenance. And so if you want the deep dive, I'm ready, I can do all the homework, go to all the visits, we can do 14 and done and then put you in maintenance. But if you're like, I think I need a slower pace, we're here for that too. We really want to make sure that every patient we take care of has a program that they can access. Me building something spectacular that doesn't work for your life, doesn't work for your schedule, means you don't get it. Like a great thing across the room, across the country doesn't help you. I want it to be there with you. We want to be there with you.
Perfect. That leads my last question on this segment. What would women experience in your models that they're not getting from all the other programs? I know you secret shopper quite a number of programs.
Yes.
And it was fascinating hearing your breakdown. It's funny because everything we've built with Bespoke has been in exclusion of everybody. I don't care what anybody else is
Right.
doing. I want to do what I think is right,
Right.
and I want to do what Mike thinks is right, and what everybody else like weighs in. We should do this, we should that, and that way we're not competing with anybody but ourselves to give everybody the
Absolutely.
best product. But because you have such knowledge on everybody else's
Sure.
program, what are people going to get with your programs, your boot camp, your immersive experience,
Sure.
and your your foundational core 4 programs? What do you think women are going to get here that just not going to get somewhere else?
So, I mean, I think for sure that they're going to get high quality physician care that is high touch. And so I think one of the challenges I've seen, because as you've mentioned, I pulled out the secret shopper, got my little hat and glasses, and I went to a few different places as I was trying to get my own healthcare sorted out, because this is my season of life too. So I'm particularly passionate about it. And what I could say is that like you will see a physician when you come to visits with Bespoke, and that we dive deep. I absolutely no names thrown, no stones thrown. Went to visits where they're like, hi, fill out a survey and we'll write you a script. Some would ask for 2 labs. Some would ask for 14 labs. Some would ask for no labs. And we're going to give me medications based on my symptoms. And I think the program that we've built is really intentional, not just on symptoms, but on long-term healthcare risks and on longevity and optimizing our health span, right? To the best that we can. That's what we're building. But
And our lifespan.
Yes, because we want to be the best we can for as long as we can, right? And it's also very intentional and it's patient focused. Like I remember going to a visit at one of my secret shopper experiences where I listed my concerns and she was kind of like, okay, go back to your PCP. I'm like, well, I came from my PCP. Like I actually need help from you. And so I think what you'll find is we're intentional, we are comprehensive, and we listen. It's a place and a space where you can feel heard and you can feel that your health concerns are raised to the front. So we'll go through the list. You come in with your list of what you need. We've got tons of great patient education materials, trackers, things that help you along the way. Looking forward to having some coaching down the line for women who are going through menopause and want to have some additional conversations about them. But education, workshops, webinars, like we are trying to add a total health package. So not just one and done, like, hi, I filled out a survey online at 3 a.m. and I went and got labs done at whatever place. And then somebody just mailed me these meds. And then I had to wait 6 months to find out if they were working.
And we talked about this earlier, but that goes back to your 2 core principles from your training, the anticipatory guidance and the health literacy.
Right.
And so, and everything, I think this is why I got so excited to embrace all of this. It really addresses, I think, these huge gaps. In spite of all the commercial attention lately that's been put on women's health, it's been treated as a piggy bank in my estimation. It has not been treated as this, foundational awakening where we're like, okay, we need to do a better job. At Bespoke, one of the things that there's twin pillars of our healthcare. It's really about health span optimization and lifespan optimization, right? So get the most out of your day today, right? Get the most, you get the most life from your years, health span. And then our lifespan is let's get the most years out of your life.
Right.
They're mutually exclusive, but they're interconnected. Right. It doesn't matter how great you feel if you're going to live a very short life. That's not not ideal, and it doesn't matter how long you live if your life quality sucks. Like that's what we want. So we want to get the best feeling and the best optimization while living as long as possible, so that you have time and ability to really enjoy your families. At least that's my vote, and that's my
100%.
So,
I mean, I think at the end of the day, I can tell you in day of the week, women run the world, and we run communities, we run families. Without us, the world would not exist.
You're all CEOs,
of course,
of your families. Yeah.
But if we aren't given the tools and the care to be the best we can be and the healthiest we can be, honestly, the community, our families, the world suffers. And maybe people don't see it on that broad of a spectrum, but I do. And that's why I'm so passionate about this. Like, we start one woman at a time, one family at a time. But at the end of the day, if a woman is feeling the best she can feel and her lifespan and health span are optimized and she can do the best she can for her family, at her job, in her community, she touches other people who do the same. So we have ripples. And so
second
I think
and third order consequence. Totally agree.
And so I think it's really important. But I love that we have the chance to prioritize this, because you're right. In many places, in many spaces, this is kind of a cash cow, right? So there's a ton of misinformation and profiteering. You can slap any lotion you were selling last week on the market and say it's for menopause. I'm getting married in a month or so. If you say it's for a wedding, the case costs triple. Somebody tried to charge me $1,500 for cake that I could get at Costco for $300. But as soon as you say it's for a wedding, the price is tripled. And I feel like that's what I'm seeing when it comes to menopause, honestly. Anything that you have that might be out there, as soon as you say it's menopause related, the price goes up, the number of answers you get go down, and everything is very black box. But we're all desperate for answers. And so people are like, well, shucks, I'll buy it this time. If it doesn't work, I won't buy it again. But you got my money this time, right? And so the amount of misinformation and profiteering related to menopause is huge. And so I love also that we're very evidence-based in everything that we're doing and everything that we're recommending. There's not a whole bunch of like weird hocus pocus in the dark. Like, you've got questions, we can answer them. We don't know everything. We'll tell you what we know, and the places that are gaps. We talk about risks, we talk about benefits, and we agree together on what are the next best steps for each individual patient. This is not a cookie cutter situation, because everybody's life story is different and what they need is different.
That's the whole point of Bespoke, right? It's specific to each person.
It's tailored.
All right. So that brings us to the next segment, what should good menopause care actually look like? So I will tell you what my original thought on this was. I'm embarrassed to admit this forever, but I thought good menopause care meant women stayed skinny and they didn't get wrinkles.
Okay.
And that they could sleep well at night.
Okay. And
they didn't have hot flashes.
Okay.
I literally thought that was my core four before I understood, before you helped me understand a much better perspective. I didn't understand anything else about it. But what do you think is good menopause care for real?
I think that the first space is that women need a place where they can speak and be heard. Right? Not gaslit, not told, get over it. You're imagining this. Where it can mark down. Because even if you mark it down now and it seems like it's subtle, by the time you have wild symptoms, perimenopausal symptoms, it's been going on for a while. And so when women are able to notice subtle changes, being able to say, I'm noticing this or a change in that, that's worth
not being dismissed.
And not being dismissed. So you need a space where you can be heard and not dismissed. You need someone who's knowledgeable about menopause, midlife care. And if they don't know, they're willing to go learn, right? Because I think what I've seen is a lot of women are dismissed. They're made to feel like they're imagining it. But the truth is, the person they're talking to is also not comfortable in that space. So rather than just saying, I honestly don't know anything about this, like, you should go somewhere else, they make it seem like it's in your head and you're going crazy. So, I mean, I always encourage patients that I'm talking to, like, one of the things to ask is, what's your approach to midlife women's healthcare? What's your approach to, like, menopause care? Because as soon as you get someone that's like, oh, hormones for no one, or I don't really know about this, then you know that it's not personal. But if you don't even know that up front, when you go in with your concerns and you feel a little dismissed, it might not be anything about you. They really don't know. So they just need you to go home. And so I think a place to be heard, someone who's knowledgeable on the topic, and somebody who is willing to work with you, right? Where you can have a true collaboration and partnership. Like, I talked to a lovely lady today, and we talked about a couple things in her history. And one of the things that came up was, well, I got prescribed a thing, but I didn't really like it, so I just didn't take it. I'm like, well, did you tell them it was bothering you? She's like, well, not really. I'm like, I want a space where you can be like, you gave me this drug and it sucks. I'm not taking it anymore. Versus you just tiptoeing away and either me thinking you're taking it or you leaving and going to another doctor. I want a space where we can have an honest exchange. And it's a partnership. So if I propose something that you don't like, don't want, let's talk about it. I propose something that doesn't work. You have to give me the feedback so we can together work to do better. But I think you should look for a space where you're heard, not gaslit or dismissed. The person you're talking to is knowledgeable, and they're absolutely using evidence-based medicine, and they're willing to learn and grow. Because again, this is an emerging field. And there is absolutely a 20 to 30 year window where nobody was really learning anything.
Yeah.
So we are all behind the 8 ball trying to learn.
It's a race. It's absolutely a race to catch up.
We're catching up.
I've noticed with myself. Like I said, it's not just, it started before you got here because I was anticipating for my wife. And it's been like, it's crazy how much I keep learning. I'm like, man, I thought I had it last week. I thought I had it last month.
Yeah.
I don't think I should.
After 40 hours on site at Harvard, I have 24 more hours to do of online recorded things. I'm going to be starting. Like literally there's like meetings and certifications and all these things to help us get up to speed. And so maybe everybody doesn't have those certifications yet, but you want somebody who's curious, willing to learn and willing to grow with their patients. And so if you have someone who's like, nope, don't know, not trying to learn, that's not going to be a good space for you to get the best care you can.
Sure. All right. So what do you think women are too often not being told about menopause care? Aside from needing to be entitled and needing to have a provider who's going to work with them and grow with them?
I feel like the things that they're not being told are, this is more than a set of unique, because every patient is different. This is more than a set of inconvenient symptoms, right? Yeah. So I think I mentioned before in the many categories we have that we talk about in our comprehensive deep dive program that, urinary symptoms, other kind of GU symptoms are part of the story. But I mean, I learned at Harvard that if you have kind of chronic recurrence of those things, that's related to more likely chronic UTIs, which are related to increased mortality. I'm like, you mean not getting hormone therapy means people might be dying? Like the fact that people's bones are breaking, like it's not just like I'm treating your hot flashes, like get a fan or go home, but that these things that we're not addressing are related to the things that we said are in our core 4 that have really significant long-term outcomes. And so it's not just about like, oh, I'm irritated because I'm frustrated because I have this symptom. Like, I want to help you with this symptom, but I want to help you have better brain health, bone health, heart health, 10 years, 20 years, 30 years down the line. And we've never been trained that these topics that nobody's talking about are not just about inconvenient symptoms today. They're about how well we can live down the road.
That has been an underlying theme of everything we do at Bespoke, has been this proactive care. And it's really an investment. You want to invest in your quality of life in 30 years.
Absolutely.
Because right now, today, it's easy to do a little bit to improve it. But what I do today actually very dramatically impacts my life in 30 years.
Right.
And how you eat, how you sleep,
right.
If you're drinking alcohol or not, if you like cigars, all those things make a big impact.
Wine. But the thing is, I think it's really important to say that being proactive is critical, like you're saying, because we're talking about catching up kind of on menopause-related education. But let's say we don't talk about bone health. We'll pick bones. We don't talk about bone health. And in 10 years, you have a fracture, and now we talk about it. The amount of work you have to do to catch up is a lot, and how well it takes is different. When you're younger, the longevity and how well all of these healthy behaviors impacts the future. Like we're building the scaffolding now. So if in 10 years you start and you're 10 years behind, you got to do triple time and you still don't necessarily have the ability to achieve the kind of outcomes you could have if you started now and were consistent.
There's an analogy I use. So I'm a big fan of Warren Buffett, and I love his investment philosophy. And he was
we should
one of
go
the
and
ones,
hear him sing at the meeting.
Unequivocally, yes. But he talks about not trying to time the market, but it's actually about the time in market. Okay. And so if you look at menopause and even bone density and things like that, like a retirement account, if you start your retirement account early in life and just let it grow and just be part of your life, it's a much bigger balance than, oh, I'm 60 and I want to retire in 5 years and I got to play catch up.
Right.
It's a lot harder at that point. It doesn't matter how much more money you're making. It's just a lot harder to plan. And so I always thought that was really great. And we've imbued a lot of his investment principles are actually my guiding medical principles for the company and for the practice, because in the end, you're trying to not lose money, which is time in your life. Right. And you're trying to grow steadily. And just keep moving forward in a healthy, robust, and predictable and sustainable way. And so a lot of our programs are geared towards patients, getting more out of their time and getting more out of whatever resources they have available and not playing catch up.
Right. And I think that's where the anticipatory guidance comes in, right? Like if I tell you in advance what you need to be prepared for, like A, we can start working on your bones now when you're 30, but B, when things start happening that you don't expect, you don't spend all this extra energy or angst feeling uncertain and uncomfortable in your skin, you can then say like, I'm going to go talk to my doctor because this is what's happening to me. And then that again, like better years in your life and every day is better versus like being surprised and being stressed and suffering in silence for years and years, crowdsourcing strangers.
being derailed from some other product.
Yeah.
What's the one saying Warren Buffett had that I thought was so funny? He said, "You always find out who took the time to put a bathing suit on when the tide goes out. Who prepared." And I thought that was so great. So again, I'm completely with you on this, and it fits so naturally into everything else we're doing. It just has a better focus on an area of medicine that I think has just been ignored for far too long, and it's been invisible. I mean, I only went to med school 20 years ago, and we just did not do this. It was almost as bad as nutrition, right? We got 14 minutes of nutrition training in medical school, right? Yeah, we got.
And there's like one question on all the tests put together.
Yeah. What do green vegetables give you, right? Like, and that's it, right?
That's it.
As opposed to like menopause, I think we talked about it for 3 hours. We probably had that much training in med school.
Out of thousands of hours of training. Yeah, no, and I agree. And I love the opportunity I have to be a part of something bigger and to be a part of the really important programs that we're building at Bespoke, because I do feel like after, like I said, I've been secret shopper. I think I've been to 6 or 8 different practices trying out what they've got. I can tell you from my experience that what we've built fills the gaps I see in other spaces. And a lot of women are really struggling and are really desperate for answers.
Totally.
And so for us to be able to say, hey, come here, we can walk through this with you. We can evaluate, we can decide what should be the highest priorities, and then we can help you get there. Like, we'll stay with you. This is not a place where you have to feel weird or uncomfortable. And you get to be a part of the push and pull and the conversation. Don't come and expect that I'm going to tell you what to do, and then that's just all. If I have a suggestion it's not working, like, let's talk about it. Like, what will work the best for you, for your life, for your family? I don't need you to come to my clinic and understand big words. I need you to understand what to do so you can make the most of each and every moment for yourself and your family.
Yeah. So on that note, what do you think is the future of menopause care?
Ooh, good question.
Where are we going?
To someplace better. To someplace better than we are. I think based on what I know, which is still rapidly evolving, where we're going is a place where a program like the Comprehensive Menopause program is the gold standard everywhere you go. In pediatrics, there's Building Bright Futures, right? So there's the whole program and it's the roadmap and everybody uses it and everybody knows what to expect and everybody knows what the key components are. And when you go for every visit, they hand it to you. It's not weird or novel. So the future of menopause care must be a place and a space where we're comfortable talking about uncomfortable things. Patients feel seen and heard. There's a very specific and intentional curriculum and roadmap that helps them follow along. Because honestly, the roadmap keeps us honest, right? I know what I need to know and learn. The patients know what they should expect of me. And if they want to talk about it with their families, with their partners, they can talk with them and they know what to expect. We're working with workplaces, right? So different businesses will be able to create workspaces that are more friendly for women in midlife. So I think that our roadmap is a great start, but a place and a space where everybody knows what to expect, people can have honest conversations about things that are sometimes uncomfortable, will make a place in a world where women can thrive in a different way than they've been able to before, and we can apply the most robust and recent science.
It dovetails with the next thing I wanted to ask you about is where, what changes do you expect to see in, say, the next year, in the next 5, and the next 10? Because I think, you talk about workplace incorporation of menopause principles. I definitely think that's a 1-year target. I don't see any reason why, corporations doing, corporate health can't do this. We do corporate health programs and we've incorporated everything you want to do into it. It's eminently achievable today, right now.
Right.
But what's that 5-year target look like? What's that 10-year target like? What do you want the world to look like in 10 years? You talk about every woman feeling the having the space and grace to talk about these things.
Sure.
But is it something where every visit you're checking in early in their 20s? Hey, let's talk about bone health. Let's talk about heart health, and proactively do that. And just everybody's doing it. It's automatic.
Yeah, I think that when we talk about let's dial back because let's return to my peds world. So in adolescence, right, we got the 8-year-olds and the 9-year-olds, and we're talking to the moms.
I'm not talking about menopause to my 8-year-old.
No, you didn't let me finish. We're not talking about menopause to your 8-year-olds.
All right.
But when you're talking to moms and dads of 8-year-olds and 9-year-olds, and you're talking about puberty, you're like giving them a heads up on how to be prepared, right?
Yeah.
And what to be ready for. So I don't think that there's really an excuse to be talking to women about menopause when they've been having hot flashes for 5 years. That's unacceptable in every way. So I think helping everyone understand this is a natural part of life and we should all be prepared is great. Like we said, if you talk to any woman, when did your mother go through menopause? That gives you a roadmap. But most people don't talk about it. Oh, well, my mother died. I don't know. I'm not sure what's happening. And so having people be proactive and having those conversations normalize is really important. As the science goes forward, right now, as we look at hormone replacement therapy, we're really excited that those black box warnings came off of estrogen, right? But one of the things that's really important is we're talking about multiple hormone changes. So estrogen, progesterone, testosterone. Testosterone is currently not labeled for women. So we're using the male formulations, concentrations, and dosing them and using them offline, off label, and they're helpful. The truth is, it's not cocaine. It's something that your body actually makes. So the fact that we're fighting so hard.
You mean your patients don't sniff their testosterone?
I mean, I can't speak to what they're doing, but I'm just telling you that it's not like an abnormal substance. Like, it's already in your body. So fighting so hard for something that's in your body and having it so hyperregulated, there are things that are actually dangerous that are far less regulated, right? And so I think having women have access to the best of care means they need to be able to get the medications, the hormones, whatever they need without so much fight. Like, let's be honest, it's not cocaine, but it is still regulated in the same way as if it was codeine. Right? Like the kind of like you need 1,100 signatures to get testosterone. But I mean, if I got a cold and I want to get whatever over the counter, like I can just get it. And that's not something my body makes. So again, something that your body makes that you need to have it replenished. I'm not saying it shouldn't be prescription. It should. But that level of regulation creates barriers.
So it's funny because it's one of the future projects I'm working on is testosterone for women's health.
Yes.
Because some of the early research I've done has shown one of the challenges, and what I tell every woman is that you don't have standardized testing.
Yes, absolutely.
And that's one of the big challenges. If we don't have standardized testing for testosterone, I can't tell if you need it or if it's helping. So I've been just back at a napkin, doing it, saying, listen, what are the symptoms you're having? Let's try this out and see if that's gone away. But we can do better.
We can do better. And the science needs to catch up, right? So we need there to be more research studies that are addressing all the hormones in general, right? Because even the range of normal for estrogen, even in menopausal women, is like wide. So one of the things we learned is, like I said, we were treating to symptoms. But then you find if we treat to symptoms and your symptoms go away at, say, 30, 55 to 70 might be the number that is the best for heart health and bone health. But I stopped treating you at 30. That's better than giving you nothing, but I'm still not giving you my best. So the science needs to catch up so we can do a better job. Yeah. But in the meantime, patients and physicians working together in collaboration can help to optimize within the regulations and the standards that we have. But the policy piece also needs to catch up and give us the ability to do better for our patients.
There was a new technology I saw at CES in January. It was absolutely fascinating. And they were doing saliva swabs for hormone testing. And that way...
Not just cortisol, but for everything?
Everything.
Interesting.
It's fascinating. I wanted to tell you about this. But so essentially what they're doing is their attitude was hormone testing should not be every 90 days or every 60 days because hormones change literally throughout the day, throughout the week, throughout the month. And so it's one of the technologies I'm going to be looking at incorporating into your program is seeing about really low cost, very accessible hormone testing where you could start tracking yourself early and often. Really.
And I think that makes a huge difference because everyone is different. And so in a space where we don't have really good standards, but we have such wide berth on what is normal versus abnormal. Like you have to work really hard to be abnormal, right? Like even postmenopausal, the numbers are wide and you can be the low range of normal, right? And still feel crummy. And it turns out if I treat you to here, you feel better. But if I treat you further, your bones are better. And so until the science catches up, we can do better. And I think, like you're saying, having better ability to test and respond not just to numbers on the chart, but how the patients are feeling. And then what we know as far as once you get to symptoms going away, how much more treatment gives us better health for bones and for hearts and for things like that.
We talked about me being a data nerd a little bit. I do love my tech. And I do love data because I like to track it, right? Sure. If you can't measure it, you can't manage it. That's been my attitude.
I agree.
And one of the things I realized at CES is that we should both go next year. And
Sign me up.
Yeah, because femtech is a big deal and it's all designed, hopefully, to help better manage, quality of life for women.
Yes.
And the projection of it and so forth, so on. So it's one of the things we do at Bespoke. Dr. Ed and I both love our technology.
Yes.
And we've tried to incorporate it every step of the way where it doesn't get in the way of patient care, but accentuates and supports and augments those outcomes. What kind of, do you have any tech on the horizon that you're seeing that has you excited? Or is there anything that really has you going? I've seen how patients can get obsessed with their sleep trackers and it takes away from their sleep quality. Right. But what are you seeing, or is there anything that you want to see? And so any future innovators out there, they can watch and work on it.
Yeah. So I think one of the things that I've seen in snatches, and I'm still secret shoppering this as well, right, is that, we've got all kinds of scales that can maybe do body composition and things like that. So obviously we know, and you and I talked about that this week, that with DEXA, it does give you some indication about like body composition and muscle and things like that. And so there are all kinds of things that people have in their homes. And I'm still in that space where I'm trying to figure out how we best vet them. If, we talked about incorporating technology into care. If you have gadgets that speak to Bluetooth, that speak to our medical record, and we can help you manage it, it's great. But I want to have solid information, because I think talking to people about optimizing your bone health is important. But when we talk about body composition and, metabolic health, and, we've talked in the past, and we'll be talking even more in the future about GLP-1s and things like that. They're great for losing weight, but if you're losing muscle and not just fat, like, that creates problems. So ways for people to track that, like you're talking about, well, hey, we can do swabs at home, and, like, you don't have to go to a whole test that costs you $700 to find out how you're doing in that space. So things that help us better understand body composition in real time versus it being a whole production that you can only afford to do once a year, I think would be great as we're helping people manage their day-to-day health, physical activity, how's their weight, but bone density, et cetera. So I don't know. I mean, I don't think we're going to have DEXAs in everyone's home yet, but anything that helps us to understand what body composition is looking like in a different way than we've been able to would be great. Obviously, there's lots of trackers, but I don't know. I don't know if there's going to be a watch that'll help you track all these symptoms and help you identify, like, oh, you've been having these symptoms, like you're in perimenopause, like you should be ready for this. I would love it if we knew enough about it to have some kind of time trajectories that could kind of prompt patients to go get seen sooner than after they've been having hot flashes for 5 years, right?
Yeah.
Like, oh, we've been noticing this. I mean, if you're going to check my pulse every single night anyway, are there other metrics you can be tracking that would help me be closer to being able to talk to my doctor in a more proactive fashion than we currently do now?
Totally. All right, good. I'm excited. We'll keep everybody tuned on this next year.
All right, absolutely. That's going to be our
January.
secret. So after we go to CES, we'll come back with a bag full of goodies.
Yes, absolutely. All right, so I want to bring this back to kind of your personal goals here, writ large. You were the chief medical officer for MEPS of Cleveland.
Yes.
You were the chief women's health officer at the VA in Ohio. And you've also served other roles. And now you're the chief women's health officer of our practice, a virtual primary practice that's licensed in all 50 states. And we've got patients that literally travel the world, and we take care of everyone. Help me understand, what are you looking to accomplish for women at large with this body of work that you've accomplished over the decades?
So women's health, like I said, I mean, I cheer for the underdog, and we are no longer going to remain the underdog because the revolution will be televised. But women's health is really important. And I'm very passionate about it. And having worked in multiple settings, in academics, in federal service, and in military service or military adjacent service, I've seen gaps. And a lot of systems are not designed for easy change. It's like the difference between steering a cruise ship and steering a canoe. And one of the things I love about Bespoke is that we are committed to making the changes that our patients need based on the science, but we're also responsive to the needs of the humans in front of us. And so I was particularly passionate about bringing women's health expertise to this space because I feel like I really have a chance to impact change. It's not a place where I'm going to show up and somebody's going to hand me a folder full of things and be like, well, that's just how we do it. And every time I need something, I have like 1,100 meetings and I have to fight for 6 months for any change. But we're really focused on doing the best that we can, health span and lifespan wise, for every person that we serve. And so when new science comes in, like we research about it, and like we reach out to the companies and we try to figure out, is this something we should be incorporating? And hey, there's a new thing, and how do we get coaching? And okay, we didn't have this plan, but like this is something that would help our patients. Let's do it. And I think for me, I always want to leave every space I enter better than it was when I got there. But I've found over the course of my career that I've been in lots of spaces where you can only do that so far. And so I feel like the structure here and the vision here means that for our female patients and for all of our patients, the sky is the limit. And I want to be in a space where I'm going to dig in deep, put in heart, soul, everything I've learned, learn more, and it matters. And the people who interact with me, the patients I see, the patients I serve can say, Doc Kumi fights for me. She's learning new things. She doesn't know everything, but she's learning new things. And we can have conversations. And I know that working together with her, I can get the very best that I can out of my health each and every day.
I can say this not just as a CEO, but on behalf of every physician at Bespoke. We are lucky to have you leading that charge. And it's a privilege, frankly, working next to you every day, even if I do feel dumber and dumber by the second when I realize I didn't know this and I didn't know that. And I was like, oh
you teach me new things every day. That's the beauty of being a team, though. Everybody knows different things and we teach each other.
That's right.
And so nobody has to feel dumber. Everybody can feel like, hey, there's a person on my team who can tell me about that. Because I know when you do all your videos on YouTube, I'm like, I don't know what he's talking about. I got to go read about that. And then you're like, do videos like me. I'm like, ooh, I'm not that smart. And so we're all smart in different ways. I am 100% serious.
Yeah.
I am quite, yes, I am not smart in the same ways that you are. But I think the two of us, along with the rest of our team, we
Yeah.
have a chance to do a thing that maybe many people think is silly, but we do have a chance to change the world.
Dr. Edney will tell you, I've been beating that drum for years. All right. So this is important to me, and it wouldn't have been had I not been married and understand that this matters. What do you want women to feel from this program that maybe they haven't felt from any from the healthcare system before this?
I want them to feel empowered. I want them to feel comfortable in their own skin, even if their own skin is on strike, quite frankly. But I want them to feel like I can track what's happening to me that is different. And there is a place and a space where I can go and talk about it. And is this a thing that it sucks and I just got to suck it up? Or is there help to be had for this? But I want women to feel that whatever the changes and however subtle they are, they can bring them here. Because again, this is a space that is not well understood and hasn't been. And like I said, in professional settings and in personal settings, the number of people suffering in silence for years and years and years is outrageous. The number of people who are receiving effective menopausal hormone therapy or other treatments, it's embarrassing. We should be ashamed. We should be ashamed. And so I want women who come to us to feel like I can bring what's on my mind and we can talk about it. Because maybe it's an early symptom of something that's coming, but you can't quite quantify it. But having those conversations early means that we can get in front of it. Because again, being reactive, well, that's just not my speed. That's not cool. But at the end of the day, a process that lasts from 4 to 17 years, who's trying to get in on anything that late? If it's going to last for 4 to 17 years, 5 to 10 years before that, you should be aware. So now we're 22 years out. And so I think we want people to be empowered. Even women that are in their late 20s, early 30s should have some semblance of education about the topic and know, hey, when these kinds of things start to happen, head our way. This is what you can do to protect your bones, protect your heart in the meantime. These are the conversations you should have with your mom and your friends, because this is a team sport. But again, I want the women that come to us to feel comfortable sharing even uncomfortable things and know that we are here as partners to help them make the most of each and every day and be able to take the best care of themselves and their families.
I got to tell you this. I know we didn't really talk about this before, but one of the reasons I was so eager for this role, I was just a kid, but I really feel like I failed my mom. My mom's a pediatrician. She's a doctor. And she told me how she suffered in silence alone. She didn't realize I even realized she was dealing with some of the flashes and some of the other issues. And it really pissed me off when I realized as I got older, I was like, this is bad. And it's too late for me to help my mom, but I want, through your program and through your leadership, I want to help everybody else's mom out there, because it really, I feel like a failure in a lot of ways, not being able to help my mom, even just to speak up to my father, also a physician, who did not know what to do or say. He's a cardiologist. Her heart health was perfect. Mm-hmm. But beyond that, none of us knew what to do.
Right.
And that's really, it's borderline criminal. It really pisses me off in retrospect.
But it's a new day, right? We're here today and we have a chance to make it different for everyone else's mom.
Yes, which is now become one of my passions.
Because I think that it's been a hard road and people didn't talk about it.
Yeah.
And people did suffer in silence. And even when they spoke up, it's hard enough to speak up, and then when you speak up, nobody knows what to do with you.
Yeah.
Right? Or you get told, go back home, you're fine, or no, it's in your head, or, literally it's in your head. And so, starting out the conversation with, okay, so this is not in your head, talk to me. And giving people that space is really important. But I think that personal connection that you have, though, will fuel a kind of passion that will enable us together to do more.
I totally agree. Now, when you came back from Harvard,
Mm-hmm.
you were literally bursting at the seams.
Oh, 100%.
And it was fun because I was like, even Caitlin was like, are you still in food, Dr. Kumi? I'm like, you have no idea. I'm trying so hard.
3 hours a day.
And I literally would, you'd be talking, I turned to her, I'm like, is this what it's like hanging out with me all the time? Because I am having a hard time keeping up. I'm taking notes seriously. I literally was like, should I record this so I can go back and make sure I don't miss anything? And when you were describing your fiance, asking you what you're doing at 2 a.m, you're like, I'm writing notes on this.
I woke up and I don't want to forget, and I have a call with Zaid and he's calling back and he's like, okay. Yeah. And he's a great guy, super understanding, but I was like, I can't forget. This is so important.
Yeah.
It's what we learned versus what we want to do. And it was in one, I suddenly saw where it met, and I didn't want it to get away because again, the program that we're developing is one that's different than I've seen anywhere else. I'm not saying no one's doing it, but it's not a common or standard model. And I didn't want to miss a thing because I wanted to make sure that we got every little bit of it captured so we could do the best for our patients.
With all of that.
Yes.
if women remember one thing from this conversation, just one,
Mhm.
because that's Caitlin asked me that too. She's like, "Well, what was your takeaway?" I was like, "That she's got a lot to say." But if there's one thing you want to make sure women take away from this conversation, what is that one thing you want to leave everybody with?
Midlife is full of hormonal changes that affect all body systems. And if anything is changing, don't assume it's in your head. You are not alone. There is absolutely help to be had. And we're here to offer you as much of it as we can to the extent that you will partner with us. But we're building programs and clinical care systems to make sure that all women can optimize their health, understanding that this is a poorly understood area, but we are on the cusp, the front lines of doing new important things. So if you have any questions about midlife health, come here. We are happy to help with you, to partner with you, to make sure that you get the most out of your health span and your lifespan.
So would you say that you want women to know that they should feel empowered and that they have a partner in us?
Absolutely. They should feel empowered. They have a partner in us and they have a voice. They have a voice. And we want to hear that voice.
What do you wish most people understood about menopause women's health that they don't right now, in spite of all the commercialization and the attention that's being
super eye roll?
Yeah.
That it's more than just hot flashes, and that
Yeah.
there are a lot of really significant long-term health issues that should be addressed that are being overlooked. And number 3, if you happen to know someone who is struggling with any of those symptoms, dismissing them, running away, buying them chocolates, going on vacation and hoping it's okay when you get back is not the way to go, even if it's hard. Even if it's hard, because it's hard for everybody. If you're interacting with someone who is struggling with their own health and doesn't feel comfortable in their own skin, that's already hard. Having everybody run away from you is not going to help you.
As a kid, that was the one thing I did for my mom. When I saw she was struggling, I would go pick flowers out of the yard and she'd look at me with this confused look, like, "How's this going to help?" But I love you. Thank you for trying. I'm like, I don't know what else to do.
Well, but you were trying.
Yeah.
But now that we all know that we can do better and be better, then you can bring, I'm not saying don't bring flowers. The ladies love flowers. Bring the flowers. But don't let the flowers be the end.
That's a great.
Don't let the flowers be the end.
Yeah, I think that's a great note to end on. For everybody out there watching and who made it through the 2 hours, I appreciate you. Dr. Kumi and I both appreciate you. We'll link related topics both in the description and in cards throughout the video. Feel free to reach out. Don't be shy. I think the first thing you can do to help yourself is just pick up the phone. We do have free consults, so patients can just kind of, just check in and be like, "Hey, I'm thinking about this," or I want to know more about that. And you'll talk to one of the doctors, not a salesperson, just to get a sense of, is this a possible fit or not? So beyond that, subscribe to Dr. Kumi's channel. She's been pretty good about getting more and more content out there.
Absolutely.
I am relentless with that content because I want to tell the world everything. And we appreciate, I think, very much everybody paying attention. So
we would love it. Thanks
until next time.